Well, welcome back. Our first speaker of the afternoon is Dr. Peter Bulova, who is a professor of general internal medicine, who began working with adults with Down syndrome in 2003. He is the vice president of the executive board of the Down Syndrome Medical Interest Group and speaks nationally of the care of adults with Down syndrome. He teaches medical students, residents, and fellows at the University of Pittsburgh and was accepted into the university's Academy of Distinguished Educators in 2009. He is clinically involved in research on Alzheimer's disease in adults with Down syndrome. He is on the NIH National Down Syndrome Registry Data Access Review Committee and is an ad hoc reviewer for several journals, including the New England Journal of Medicine, the Journal of Intellectual Disability Research, and the American Journal on Intellectual and Developmental Disabilities. And I actually needed to mention to you that the session this afternoon is on aging. And so this is actually the first time that we've done something like this, but felt that this is a very important topic, especially if we think about the lifespan. So with further ado, Dr. Peter Bulova.
Hey, thanks so much. Give me a second to share my slides. Okay, is that looking, can everybody see that?
Yes.
Fantastic. Okay. Thank you so much for having me here today. I'm so glad to hear that you're now including aging, because that's a couple of my slides will be kind of about how this is a very important topic that is going to get more and more relevant throughout all of our careers. This is a topic that I face every day that I'm in clinic. I'm happy to get a chance to share this with you. I will start with a case. So I'd like to talk about David. David is a 52-year-old with Down syndrome, and caregivers notice that he's having trouble in his group home. He's been unable to do his laundry anymore. Previously neat room is now messy. He's hoarding food there, and now he needs assistance getting ready in the morning, which had never been an issue before. And I'm hoping this is a general case that people may have seen before. So the questions that I would like to address, we'll talk about through today. How specifically would we address a case like David's? Does he have dementia? Does he not? And how do we tell? And then some of the broader issues, like, is dementia inevitable? If you are a pediatrician out there, I want to make sure this is relevant to you too. So I'd like to talk about how do we prevent, manage dementia, and just how do we understand dementia in adults with Down syndrome. And I'll talk a little bit about, are there things that we can do for prevention? What are the early signs that we should be looking for? And how do we counsel all of our patients? And I think that dementia and Down syndrome is a really nice model for dementia in general for people with intellectual disabilities. So I think it really does apply to the whole field. So the good news, I would like to start out with good news. The good news is that adults with Down syndrome are living longer, healthier lives than ever before because of improved medical care, technology, environmental conditions. The challenge associated with that is that we're caring for a population where there is not nearly as much experience and much less research data. So I'll give you a slide. This is, I think, one of the most hopeful slides. I think when you see that there was really very little improvement in terms of life expectancy for most of the last century. And then in 1970, you see this dramatic increase in life expectancy. It's leveled off much more going forward from 2010 to 2020. It was probably in the mid 50s. It's approaching 60 at this point, but really hasn't moved much past that. But you can see we have lots of data for kids that's been around for more than a century. But for adults, we really haven't seen very many of them until just the past 50 years or so. And again, I like to start out with what are the positives, because I'm going to be talking about dementia, so I want to make sure you get some positives about Down syndrome too. What are the health benefits of Down syndrome? The patients that I see, most of them have very low blood pressures and very low pulse. And tend to have a lower risk of coronary artery disease than my patients that don't have Down syndrome. the risk of solid tumors is much, much lower than in people that do not have Down syndrome. I like to think of these as the superpowers of people with Down syndrome. It's how I talk about it with our families. And then the last one is memory. There are many families who count on their family member with Down syndrome because they remember every birthday. They're very good with dates and names. They can recite movies scene by scene. And I think that's partly what makes it so difficult when our patients do start losing their memories when they're into their 50s. Okay, so now a little bit more about dementia. So dementia is a neuropsychiatric syndrome of memory loss that prevents new information from being learned and is characterized by decline in intellectual skills. And that impairs social or occupational functioning. And when you think back to David, I think he was starting to have some issues where he was having troubles both socially as well as some of his activities of daily living. So we were seeing that. The caveat about this is that dementia is something that you have to see changes over time. And I think that's one of the things that makes diagnosis difficult. So why is it hard to diagnose early signs of Alzheimer's dementia in Down syndrome? And the first, I have four points about this. The first one is you see variable levels of baseline functioning. And when I think about the patients that I see in clinic, I have some that are nonverbal and have never been verbal, that really rely on caregivers for many of their activities of daily living. And then I just saw someone this week who was very excited to tell me that she's getting married, that she's going to be having a commitment ceremony with her partner. It's pretty wonderful. She has very high level of functioning, and I think it's difficult to assess patients with such varying levels using the same tools. So what we find is that we have a very limited toolbox for what are standardized assessments to assess for Alzheimer's. All of them depend on caregiver reports. So I have some patients that have lived with the same caregivers for 20 years, and it is so much easier to hear about subtle changes than someone that comes with a different caregiver every single time that I see them. And then the last one is that changes in functioning may be due to quite a myriad of other issues, and not everything that is a decline in skills is Alzheimer's. We will talk much more about that too. So when we talk about Alzheimer's, this is my only histology kinds of slides. I have just a couple of 2 or 3 of these. But I think what is fascinating about Alzheimer's in Down syndrome, so the Down syndrome has 3 copies of chromosome 21. The precursor for amyloid is on chromosome 21. So our patients are getting a much higher amount of amyloid protein than people that only have 2 copies of chromosome 21. And that's why we see such the earlier onset and the higher prevalence of dementia in our patients. So we have 4 stages. We start out with normal, so no disease, no symptoms. Then we move into that pre-symptomatic Alzheimer's, where if you do studies, so if you look at a brain MRI or a PET scan, if you look at blood tests, you might see early changes, but absolutely no symptoms. Then the next stage is mild cognitive impairment, where much more significant changes on imaging and on blood testing, and definitely on neuropsychiatric testing, but you're not seeing changes in activities of daily living, so more subtle changes. And then when you've reached the stage of Alzheimer's, which can be mild, moderate, or severe, and we see this progression over a couple of years, and there it's a combination of all of those things. So what you'll find is that these all develop slowly over time. It always goes the same way. You start out with first seeing amyloid changes, then you might see the tau pathology, which is another sign of Alzheimer's. And then you'll see changes on MRIs and PET scans. And then finally, after that, it's when you would see any type of cognitive impairment. So to put that a little bit more simply, the neuropathologic changes start 15 to 20 years before you have any clinical signs or symptoms at all. Virtually all adults with Down syndrome will have the hallmarks of Alzheimer's disease, but have no dementia. So they will have, if you did blood tests, you might see some signs of amyloid. If you were doing scans in it, you will see these changes, but having no dementia at all by age 40. So that's the difference. Is at 40 you'll see definite changes of Alzheimer's disease, so the baseline brain changes, but you will not see any changes on cognitive testing or on abilities. When I talk about is Alzheimer's inevitable, if you're looking at the cumulative incidence of Alzheimer's disease. So the good news is you're seeing very little Alzheimer's here early around age 40. It's very quite rare. And then it gets more and more common, and then you see it increases dramatically. The average age of onset is between 52 to 56. And then it becomes much more common as our patients get into their 60s, probably 80 to 90% by the time you're seeing someone in their 70s. I read a wonderful paper by Brian Chacoin, who runs a center in Chicago, of an 83-year-old who did not have signs of Alzheimer's. So it's not something that has to be inevitable, but a very, very common, and something that I plan for in all of my patients. And we talk about 52 to 56 as the time when it's common. So the difference in survival between the general population and those with Down syndrome, from the diagnosis to someone who passes away, 8 to 10 years in the general population, where it goes from mild up to severe. And in Down syndrome, that's truncated. So at the time of diagnosis, it's more 5 to 7 years. And that's because of two things. One is that because there is more rapid amyloid deposition, it probably does progress faster. But also in people with Down syndrome, in the past, it's really been caught often at later stages because of lower baseline functioning. So it might get caught later and also probably progresses faster. So what do we do? Do we have any guidelines? Is there any papers that we can hang our hat on? So luckily we have one very good comprehensive medical care guideline article that was published, the Global Medical Care Guidelines. And this was published in 2020. It addresses lots of different issues related to Down syndrome. If you have any questions about what are our true evidence-based guidelines, they have a nice handy handout. And this is on the global website, or if you go to JAMA, you can find it there too. The guidelines give you ideas of where to start screening for things. And there are two very nice concrete recommendations regarding dementia. And let me go over those two for you. This is the best that we have out there. So the first one is caution is needed if you're diagnosing Alzheimer's type dementia in anyone with Down syndrome under the age of 40. So there are many things that will cause a decline in skills, and you should start looking for all of them in anyone who comes to you who's under 40. If they're over 40, and this is recommendation 4, so we should do some sort of assessment, baseline functioning at age 40, and we look for changes in 6 different domains, and I'll go over those for you. And I do this assessment of those 6 domains about once a year for anyone over the age of 40, and make sure that we do a baseline at age 40. What are the triggers for dementia? And I think this is something that's interesting and somewhat unique for Down syndrome compared to the general population, is often we do see some sort of a trigger, some sort of life event. And that's when you start to see the true changes in activities of daily living is after that. And it can be an environmental stress, a change, a life stage change, or a transition. So the times where I will see that is often someone will be living with their parents. One of their parents gets very sick or dies, and they or can't take care of them anymore, or they can't live at home anymore. They move to a group home, they move in with a sibling, and there's a major life transition, and that can start some of the process in someone that already has the brain pathology, but has not shown any signs. It can be the death of a sibling. It can be the change of a caregiver. It can be this a really bad hospitalization. I've had a patient who was admitted to the hospital for pneumonia, who was 50, and came out with a huge decline. It seemed to start the cascade of symptoms of Alzheimer's dementia. What are the symptoms that you should be looking for in our patients over the age of 40? The most common ones, so memory loss, a lot of confusion, disorientation. I've had patients that get lost in their group home or get lost at home. They can't remember where the bathroom is, wandering, changes in day and night. So having trouble falling asleep at night and then trying to sleep all day. We talk about loss of empathy. Our patients, you may have heard about this with people with Down syndrome. They have a very high emotional intelligence and can really read the emotions of a room. And when you see that loss of empathy is a red flag, a really warning sign of something like Alzheimer's or another problem like that. A loss of organizational skills. And you saw that with David, that his room was now messy. Used to have a very nice organized space and really lost that organization, lost the skills to be so organized. And then interestingly, as we get into some of the physical findings, weight loss is a common early sign that our patients have an unexplained weight loss. And as I said, our patients seem to get less cancer, which is wonderful. If I heard of weight loss in someone, in my patients without Down syndrome, that's one of my big worries. I worry less about that in Down syndrome, but I do worry about somebody having early signs of Alzheimer's. The other physical findings, and this is one to look for, is the change in gait. And that can be an early marker of decline. We talk about gait dyspraxia, which the definition is diminished capacity to correctly use the legs for ambulation, or in other words, difficulty walking, but they have to make it sound complicated, and not attributable to other factors. Our patients also get early arthritis. So this would be, if it's unrelated to that, I have a patient that came in with pretty bad knee pain and was limping. Definitely not due to Alzheimer's. So, if you're looking for changes that are happening all the time, and these are the common ones for Alzheimer's, would be difficulty initiating walking, having trouble taking that first step, having more trouble making turns, a shuffling gait. So these are things that in my other older patients, I might think Parkinson's. But in our patients with Down syndrome, more likely to be Alzheimer's. Fear and avoidance of obstacles, and stairs are the most common one that we'll see. Really having a lot more trouble navigating anything so nice, even changes in color of the floor. So I might have trouble going from one room to the next if it goes from a white floor to a black floor, something like that. The other very important physical findings would be new seizures are all inevitably related to Alzheimer's in anybody over the age of 40. New incontinence, and we think about it as not that they didn't have time to get to the bathroom, but they just don't seem to care as much that they're having incontinence. And then any real major significant behavioral change after the age of 40. So what type of evaluation should we do? What are we going to do for David? And the first thing that I will do is a very good history and physical. And what I'm looking for are all the kinds of medical issues that mimic dementia. And I will give you the most common culprits in a couple minutes. The very specific things that I look for that can be other causes that cause a decline that are not dementia. And then I'm going to give you a form called the NTG-EDSD, which I will explain in a minute. And these are the 6 domains that are characteristic of dementia. So changes in activities of daily living would be the most important. Then you have changes in language and communication, sleep-wake change patterns, and there's a myriad of changes you can see. Ambulation, as you all know now, what kind of things to look for with ambulation. Memory changes, and there's a couple things in there to look for. And then a major change in behavior, a major change in affect. Someone that used to be very social becomes very withdrawn without another good reason. So the NTGEDSD, so the National Task Group, which is part of a group for intellectual disabilities and dementia, came up with this form. The EDSD is an early detection screen for dementia. And this has been, for anyone with intellectual disabilities, I think this is a great screen. You can use this for, we use this for all of our patients with Down syndrome. You can use this for anybody with any intellectual disability. if I am doing this type of a study in one of my patients without Down syndrome, I'm looking for major problems in cognition. Here I'm looking for changes in cognition. So very, very different thing that I'm looking for. So I'll give you an example of how things look on this survey. So this is for activities of daily living and language and communication. So for activities of daily living, we're looking for things that have always been the case. And if that's the case, then I don't care about that at all. It's not a change. Always but worse, yes, that's a change. New symptom in the past year, that's the most significant one. And that's a column I look for the most as a red flag, a worrisome finding, or does not apply. So you can see there are 1, 2, 3, 4, 5, 6, 7 areas of activities of daily living. Our patients will get a score from 1 to 7 for this one domain. Each domain has I think there are 55 points you can get all together of the 6 domains. In language and communication, you can see these are some of the things that we look for. It doesn't initiate conversation, all of a sudden having trouble finding words, not able to follow simple instructions. And that's an easier one to test for. Getting lost in the middle of a conversation. These are all the things we look for. And if someone has all 6 of these domains, very strong predictor that it's dementia. The studies that I've been a part of use cutoffs of changes of 7 or more would be concerning over a year. And so of these 55, if you see 7 new changes. I want to give you another case. So a patient who I saw in clinic, he was 44 years old, and he came to me with a seizure disorder. This had been going on for probably 6 months or so. He was having seizures on a daily basis, and he would have syncope, so he would pass out. The seizures tended to happen after lunch and almost every day. And what would happen is he would kind of start shaking and throw his head back, and then he would come back. They put him on anti-seizure medications. The first one put him on had no effect. He had the same episodes. Second anti-seizure, anticonvulsant medicine, and then he was still having episodes, so they added a third one. And at this point, he was really groggy. They sent him over to our clinic with the possibility of this early onset of his dementia. And I got to spend an hour with him, which was really nice. I got to see one of these events. And I thought it was so interesting that it happened after lunch every day. And it turned out that he had changed a lot of what he was eating. He was much happier having milkshakes, things that were easier to swallow, but also things that had a lot kind of dairy in them. And it just turned out that he had really bad reflux. And that's why he was having these episodes after lunch. So we gave him an acid blocker, and his seizure disorder went away. And so we undiagnosed his seizures and undiagnosed his dementia. It was just something he wasn't able to tell anyone. He couldn't tell anyone, my throat's really hurting and that's what I'm doing. It really took time and knowing what are the kind of conditions that are quite common in people with Down syndrome. So I'm going to give you a list of some of the things that we look for. So what are the conditions that can mimic dementia? And the most important ones are mood-related disorders. And as I said, these can be, while dementia can be triggered by some sort of major change, some major adjustment, that can also just be new depression or new anxiety or OCD, so obsessive compulsive disorder, which can start with some sort of a major change. So those are the ones that are the most of undiagnosing dementia. If anyone comes to me at the age of 28 with a new diagnosis of dementia, I'm going to spend a lot of time on this list trying to find out which one of these is much more likely. I've seen many people with thyroid problems. It's very common in people with Down syndrome. Probably about 40% will have a thyroid problem at some point in their life. And this is one that can start very late in life. B12 deficiency is one that we screen for in anyone with or without Down syndrome as something that can cause cognitive changes. And menopause. Menopause tends to be earlier in people with Down syndrome than in the general population, often in the early 40s. But it can cause enough fogging of the sensorium, and in someone that already has challenges with cognition, can cause a major decline. And then a couple other things I have: really significant constipation, urinary retention. Patients get so focused on that that they have trouble concentrating. And any type of pain, new onset of pain looks like a decline in skills. The other one that's very common in people with Down syndrome is sleep apnea. And we try to evaluate everyone at some point for sleep apnea, as it does cause, especially if major issues are more with sleep than in all of the other domains. So my guidelines for you are to do a psychiatric and medical evaluation before making a diagnosis of dementia, especially in anyone under the age of 40. In our patients that are between that 52 and 56 range or higher, the chances of it being Alzheimer's is much, much higher. So the positive predictive value goes up a lot in our patients that are into their 50s. So what are the treatments for dementia? And I won't spend very much time talking about medications because they are not the mainstay of therapy. The medications, where there was a trial for prevention using donazepam. It's only a 12-week trial, no significant results that came out of it. Other studies that I've seen for other medications haven't seen any long-term or randomized controlled trials that show benefits in adults with Down syndrome. There is some hope for the future. There are some ongoing trials that are looking into monoclonal antibodies. So these are antibodies against amyloid, that if there is amyloid deposition, medications that will help the body to recognize this as foreign and have the patient's own immune system clean up amyloid plaques. So I'm hoping that's what's going to be the mainstay of therapy in the future. There are already trials ongoing. There are some medications that have been approved for people without Down syndrome. There are no studies that have been completed for people with Down syndrome yet, so that haven't been used. In people without Down syndrome, the medicines have not prevented or reversed Alzheimer's, but they've slowed it pretty significantly. So it's definitely some promising results. So if I'm not using medications, what do we do? So I think about what are the non-pharmacologic things that help anyone who has dementia. And this is not just Down syndrome, really applies to anybody with any intellectual disability. Anything that our patients have what we like to, what we call an expressive aphasia. So there's a lot of trouble having their thoughts and putting them into words. Don't do as well with verbal communication. So do much better with music. Do better with other sensory inputs, music from their childhood, smells of foods that they've loved. Those are kind of picture books. Do much better with videos, and then having a small group of dedicated caregivers. Very important to have predictability, consistency. Our patients really thrive when they have a good set schedule. 2 more slides to go. What are prevention strategies? So Brian Scottco, who is a geneticist who works up in Boston, works a lot with, he has many families with kids know that dementia is something that they may have to worry about in the future. And they say, what can we do? And this is what he's talked about, and there is definitely data behind all of these. No reason not to start early, or yes, please start early for all of these things. So he talks about smart actions that might boost cognition. Number one, socialize. We want our patients to be as involved as much as possible with other people, trying to stay away from social isolation. I think the time around COVID was really difficult on so many of my patients. M is for move more. Physical activity is fantastic for our patients. This is one of the only interventions of brisk walking 3 times a week in the elderly tends to help to put off when Alzheimer's might develop. Activate the brain. This is, instead of crossword puzzles, it could be any ways that you want to keep the brain active and stimulated. Food, so reducing sugar, reducing fat, reducing junk food, healthy foods, whole foods, I think is a great step for anyone. And then I think this is the one I do the most, so treating medical issues. If our patients have obstructive sleep apnea, much likely to have an earlier decline, more likely to get Alzheimer's at an earlier time. If they have underlying thyroid disease, if they have untreated psychiatric issues, all of these things are likely to be the process where they might get dementia. So I always feel my job is to make this have them be as healthy as possible as they get into their 40s, 50s, and 60s. So my take-home points: dementia is the most significant issue that faces adults over the age of 40. But there are several conditions that mimic dementia that must be considered before making the diagnosis, as treatment options are limited, but the treatment for things other than dementia are actually pretty great.
Dr. Bulova, thank you so much, and
Yeah.
really appreciate your including strengths of people with Down syndrome earlier in your slides. Um, and I guess for everybody, we actually, Dr. Scotko was the speaker at our conference several
Ah, fantastic.
Um, so I could first, more of a comment, but it sounds like continuity of care is really an important aspect of sort of knowing the baseline and identifying sort of subtle changes early on. And it's more difficult when there's a lot of discontinuity of care.
Yeah, I absolutely agree that our patients get very attached to their caregivers too. So I think it takes a lot to make those transitions. And if you're going to have a transition to a group home or moving from living with a parent to living with a sibling, I think doing that relatively slowly is very helpful for our patients. It's hard, don't do as well with really abrupt changes.
Mm.
Um,
And I'm wondering, during such sort of transitions, whether you sometimes see both. In other words, there's maybe depressive symptoms and also early signs of dementia at the same time.
right. Right, exactly. So if I do a screen of these different domains, if it's really just in mood and affect, I'm much more aggressive in trying to treat the mood and see if this isn't really a true start of dementia. Um, but sometimes you will see, because the transition is something that can trigger a cascade of all these different domains. But treating the depression is really helpful, both with medicines or with just therapy or more socialization, things like that.
So there's some questions in the Q&A.
Yeah,
So some you may have already answered in your presentation. So question one is there any way to try and prevent it? And
yeah,
I know you talked about the 80-year-old who didn't have
yeah.
dementia. So what's different about that 5% maybe that, do not demonstrate dementia? Is that known?
It's not known. It is not known. I would expect that people who have mosaic Down syndrome probably have a lower risk. I think that patient didn't. She just uh, didn't seem to develop the cognitive changes. I'm hoping we will find out more. We've been doing a lot of studies of doing PET scans of brains of our patients, and then 2 years later, doing checking again to see where the changes are, if it's a specific spot where amyloid has been deposited that causes more trouble.
Mhm. So the next question is so very, there are a couple of specific questions.
Yeah, sure.
And so what is your opinion on use of G-tube, gastrostomy tube, with Down syndrome patients with progressive dysphagia?
Yeah, this is a really important question, and I've encountered this a lot when I start my if I have a patient that develops what really looks like dementia. This is one of my first conversations with the families, um, because so many of our patients have dysphagia, so many patients have difficulty swallowing. So this is probably the first thing that can cause mortality related to Alzheimer's. Um, so, if it turns out that someone's had very early uh, troubles with swallowing, um, I'd be more likely to say, sure, maybe a feeding tube would help to give them several years if that's a problem, if they're having recurrent aspiration. If it's much farther along, then I think it's not nearly as helpful for. And so in the patients that do not have Down syndrome with dementia, putting in a feeding tube of any kind doesn't seem to prolong life very much because they pass away from other things. Still can have aspiration even with a feeding tube, but I think our patients it's a little different. It's a unique population because we do see early problems with swallowing. I have entertained them in some cases. Most cases, families have decided not to, um, because it's another site where you can have problems. Our patients love to pick at things, so there are lots of complications with putting in a feeding tube.
Ah, yes. And so then another question, I think this is a pediatric slash non-pediatric question.
Yeah.
So can C-spine instability present in the elderly?
Oh, this is great. Yeah, so in those guidelines that I put up there, we talk about atlantoaxial instability, which is a compression of the spinal cord. Our patients often have more space between C1 and C2, the first two vertebrae, and they can kink off the spinal cord. That can occur at any age. We don't screen for it because if you do screening tests, 20 to 30% might have positive screen, whereas only 2 to 3% may develop it. But if I have a patient with acute onset changes, probably that's the first place I'm looking. If somebody all of a sudden can't walk, I'm going to be doing an MRI of their C-spine. So that's a great thing to rule out.
And then a question about treatment. Thoughts regarding benefits of Aricept Namenda in this
Yeah,
population?
yeah. So there was that one trial of donazepam, which is Aricept, which didn't show any benefit. Very small trial. I think that our patients have so much amyloid deposition that medicines like donazepam that just boosts brain activity doesn't do very much. There was a study called the Meadows trial using Namenda, which is memantine, and it was done by the drug company that makes the medication. They did a prevention, they did treatment, and then they did a control arm. And I was sure that they were going to say, "Oh, this drug works really well," but the even the people with the drug company found that there was no benefit from from the medication, and in fact, there was more of a trend towards behavioral problems and probably some stomach problems with it. So it didn't seem to have any benefit. And I think it's because there is just a lot more amyloid deposition, so things that just boost brain function have very little effect.
So this might be the last question, but I was thinking about the six symptoms that you had described as
Yeah,
stories, and probably the need to repeat the screening on a periodic basis. And so a speculative question, which is, do you think AI might help in early detection? And then a related question, which is that many of our patients see many different sort of providers, not necessarily only the primary care provider, but maybe, and should we all be as a sort of a large medical family look for changes versus sort of asking one of the usually the primary care provider to do this.
I think it has to be a little, I think everyone has to be involved because the changes can be quite subtle early on, or in someone that has really significant cognitive problems, they present very late. So the most helpful person is going to be the one who knows them the best. I think the primary care provider is going to be the one that has this tool and can put it all down on paper, but they're going to be relying on the caregivers. So it does take a village. AI is a great question. So much of this is going to be based on caregivers' assessments of people. AI might know the best questions to ask and may help to do some of the pattern recognition. AI is definitely going to help us to know what are the earliest findings, what are the later findings as we put all of our data together.
Well, thank you so very much for such an important aspect of aging.
Absolutely. Thanks so much for having me. I'm so glad that you had this as a topic at your conference because as I said, that we're seeing more and more older patients, so these are going to become much more common over time. Great. And thank you for taking care of the patients I myself love to take care of.